we're losing some of your audio, Dr. Smither, but let me ask Stella Whitney-West to respond to that, and also Dory Gabolo here to respond. So is there pressure in your practices? Has there been pressure, or would you imagine the coming of pressure to say that you have to deselect or to not provide care to certain people? Do you think that'll happen in this marketplace, in communities? What do you think, Stella Whitney-West?
Well, I think Dr. Smitherin is right. In fact, it's already happening. I think Dory and would agree. We are federally qualified health centers, which means that we have a responsibility to provide service to everyone, regardless of their ability to pay. But many patients come to us primarily because they do not have access to any of the private providers. There are clinics and private providers that will not take patients who are on Medicare or medical assistance, or they have a ceiling. And once they reach that number, which is based on, again, on their reimbursement, then they close the doors. We don't close the doors. So that already is part of the practice. And so the idea then that you're going to have people who are seeking care in the later stages of disease, we're seeing that now as well, as the uninsured is increasing, people delay coming in. So this whole country, this healthcare system is really not designed to achieve the quality outcomes because they don't put a premium on preventative care. They don't put a premium on making sure that access to care is available to everyone. So I think that the doctor is correct that before we even talk about this whole notion of pay for performance, we need to put more emphasis in making sure that everyone has insurance, making sure that the infrastructure will support quality health care for everyone. Then we can start talking about that. But right now, this pay for performance is going to create a much larger gap than we already have.
And who's driving pay for performance? Whose interest is best served? On the one hand, you could say it ought to be the consumer because the marketplace is simply working itself out. But I think there's probably a skeptical response to that statement that I've just made. What is the source? Who's driving pay for performance? Dory, what do you think?
I think it's another thing that government wants to impose upon us to say that in order for us to give you what you deserve or what you have worked for, you got to show me evidence that you're doing what we want you to do. So it's more of a control that the powers that be would want to have on healthcare and healthcare outcomes. I remember reading something about they wanted to do a performance-based measure with education. Mm-hmm. And all these things are just more instruments to use to control society, to control what people do, and not giving them the freedom to be the center of the solution versus government trying to impose what they feel would be the most appropriate solutions.
Dr. Puckren, let me ask you to weigh in here again. Same question. So what's the motivation for pay for performance? Who's behind it? Who really gains if it's not the consumer? Theoretically, it should be the consumer that gains, but if it's not the consumer, who gains? Whose interest is represented by the drive for pay for performance?
Yes. Well, pay for performance really got started. It's a purchaser-driven issue. There's a desire to control healthcare costs. It's shrouded in issues of evidence and quality and all of that. But at the end of the day, it really is an issue of controlling cost. One of the things that a patient should understand is that oftentimes, certainly in the commercial world, the health plans go to a physician and they provide them a monthly payment for each patient of theirs that the physician sees. Then the health plan says, I'm going to take, if it's $40 a month per patient that we're going to provide you to cover the services for that patient, we're going to take 2 or 3 of those dollars back and we're going to put them in a pile over here, and we're going to set up these performance measures, and you're going to compete essentially for those extra dollars. And it really puts, as the doctor was suggesting, it puts minority physicians who are treating minority patients at a real disadvantage because of issues of comorbidity and all the other things that we've talked about. There's a real incentive of purchasers to drive, pay for permits. They're trying to control cost. And I think it really puts minorities at a severe disadvantage. There are no adjusters in the system to take into account the severity of the disease, the issue of transportation and poverty and all the other things that we've talked about. And I think unless the minority community speaks up and demands that these systems be more sensitive, we're going to see a system that's going to exacerbate healthcare for minority populations.
Let me ask you your thoughts on
Can I make a comment?
Yes, sir. Please go ahead, Dr. Smitherman. Go ahead.
I'd like to add to the doctor's statement. In the 1980s and we saw cost containment measures that were prospective payment. That is, we're not going to retrospectively pay a doctor when they send in a bill. We're going to set the amount for the reimbursement. So no matter what you charge, we're going to pay you X. That's it. Then we transitioned into managed care, which was also a payment methodology. The payment system was really built to control utilization, meaning physicians had high volumes of use of different diagnostic procedures, et cetera. They wanted to contain that by managing the use of those different services. Well, despite prospective payment, despite managed care, we saw an actual small plateau per minute in the cost. But right now, premiums are increasing in double digits on an annual basis. That means healthcare premiums are going up 11 to 15% on an annual basis. I can tell you in my state, over the last 6 years, healthcare premiums have increased by 70%, and median earnings has increased by 6%. So the healthcare premium is outstripping average earnings. So what has happened is, since none of these previous payment methodologies have really worked, we're now going into what I call the payment methodology of the decade. So we're now going to transition into, let's try another payment strategy. Cutting and capping the cost didn't work. Trying to control utilization of services didn't work. Now we're going to move into, let's talk about quality, as the doctor said. We'll use that as a veil for cost containment and shrouded in sort of the quality issue. And so these are different iterations of the same sort of strategy to contain cost. And I think that the problem is there wasn't a lot of thought in the implications of these kind of payment systems on disenfranchised, sicker, poorer, more vulnerable populations. And I think that's the concern.
And so what are the thoughts? What are the ideas that are coming from the practices that serve sicker, poorer populations? It seems to me that you both are making the argument that change won't come until it comes from our minds and our experiences. And it seems to me that we're at a place where there is a significant and particular opportunity with the new Obama administration and its declared emphasis on healthcare and change. So let me ask you what your hopes are. What will happen in the movement of policy that will address and put front and center the concerns of patients, the concerns of communities, the concerns that reflect our cultural experience for the Black community and communities of color? How do we make sure that our voices go into the equations that create the policy for the Obama administration? Dr. Puckrine first, and then Dr. Smitherman.
Well, first, I think we ought to understand really what we're confronting. Our science is doing very well. You look at the rates of cardiovascular death